Everybody, welcome back to Burst TV. I'm really excited today. This was kind of a random opportunity to interview Dr. William Nudera. He's an endodontist, first of all. You got to practice in Bloomingdale, and you specialize in
Correct.
endodontics. And first of all, thank you for
That's
your
right.
service. I know that you served in the Air Force, so we appreciate that.
Yes, thank you.
So in the midst of this crazy situation, we've got this pandemic. Most dental practices are closed down right now completely, or maybe just seeing, your true painful dental emergencies. So you being in a specialty practice, there are a lot of oral surgeons that are still open. You're able to still serve your patients, which the first thing that I want to point out is so important right now to be able to keep patients out of hospitals. That's the
Agreed.
last thing that we want to do. But I'm sure that we'll get into the topic of like what your setup is right now with staff and whatnot. But what are some of the things that you had to do right away to like sit down and say, okay, what can we do to implement differences in our personal protective equipment, like the processes that we have for patients that are coming in right now during all of this?
So it's interesting when this whole thing came out, back in maybe late February, early March, we start getting phone calls about these sorts of things. The conversation starts opening about what we should be doing about infection control. And my immediate response to that was telling my team, well, when a patient calls and they ask us what we're doing differently, my response was, well, tell them we're not doing anything differently because we practice universal precautions.
Yeah.
And why would we do anything differently? Because we always treated everyone like they have some sort of infectious disease. So by saying, well, now we're doing this, that, and the other tells us that, well, maybe we weren't doing it right the first time. So I'm like, well, I don't want to sit there and make people think that we weren't doing everything we could before. But it became very clear to us towards maybe mid-March, towards the end of March, when the mandates started coming down about closing practices, that, well, maybe we should look into our current infection control protocols, and maybe we should reevaluate them and see what we can do differently in order to, number one, protect ourselves and our team, and number two, protect our patients from not just themselves, but each other. So that's when we started looking up into the more advanced PPE, and we looked into different disinfection protocols, and that's when it really started hitting home for us, is at that particular point in time.
Yeah. So I had a good conversation with a friend of mine whose practice stayed open for a little longer than what was recommended. And I said, well, listen, if you guys are going to stay open, maybe take the magazines out of the waiting room, maybe have patients wait in the car and not gather in the waiting room, things like this. And the reaction that I got was as if that was madness, just making these simple changes so that it is effective, but also so that your patients can see that, during these times you are taking extra precaution to protect everyone in that building. And, not to ruffle feathers too much, but some people do feel like the flu kills more people. Like, what is it about this that's different? That is this an alarmist type situation that we're dealing with, or are these valid concerns that we need to maybe take into the future when we open back up? Do you have any thoughts on that?
So it's difficult for me to give anybody any sort of idea on timing and what we should be doing. But what I do know is that our protocols that we put into place now, not just with the article that I recently wrote about splitting our staff up into two separate teams, just to make sure we can maintain our office from being open, but we're in a common office building. So we've got common hallways, we've got common elevators. So we've got everybody else who also, there's another dental practice here across the hall from us who is in every once in a while to see an emergency here and there too. So it's everybody that touches the elevator button. It's everybody that turns the handle on the door to get into this main commons area. So we've actually closed the doors to our main office and pretty much made a makeshift holding area outside in the common area. So when the patient comes in, one of our team members will go out and they'll take their temperature, and that's our first qualifying measure to whether or not they can be treated. They have to have a certain temperature before they're even allowed into our office. office. And before they come into the office, we have them sit out there for about a 5-minute holding period. Because what I've found over the last 21 years of being a dentist is people tend to make decisions based on their own personal interests. And if they're in pain, they're going to pretend they're okay just to get out of pain, regardless of what else may be going on, because they may not understand the magnitude of what's happening here. So it's hard for somebody to hold a cough or hold symptoms in for 5 minutes. So once we take their temperature, they sit out there in the holding area for about 5 minutes before they're even allowed into our office. Because if a patient comes in contaminated and symptomatic and they start coughing in our office, well, now our entire office is contaminated. Our team is now not as protected as they could. So that's one measure. And then when the patients are allowed into our office, they're not allowed to touch our handles. Our staff opens the doors and everything is wide open, so the patient can then travel right from that front door all the way right into a treatment room. They're not even waiting in our waiting room anymore. And that was another thing that we had to implement as well. But as far as how we're going to manage this when we come back, and that's where the strategy we're trying to figure out right now, because as of before March and February, we would double book patients sometimes with a treatment and then a check, a tissue check, a suture removal, maybe a quick consultation while we let some sodium hypochlorite soak a little bit inside that tooth. Well, now with all the gear change out, that's going to take a couple of minutes, if not more, like 5 minutes to change rooms around. So I can no longer get up and do a quick check next door and then pop right back into my treatment, because it's just not going to happen. So how are we going to schedule our patients? We're going to have to do more slow dentistry and kind of slow down a little bit, put the brakes on things. And for a lot of businesses, people that are more business oriented than clinical oriented, they're going to want to push and push and push, but we've got to be safe and we've got to continue making those good, smart decisions.
Yeah, that's a good point, because once the floodgates open, I'm like, guys, you can't just go in full force, like, and double, triple book your schedules and just pop in and out of these, especially in a general practice, hop in and out of the hygiene appointments, as if it's business as usual. That's just not going to work. So tell us about, in the new dentist, this is what prompted our conversation. You talked about this split schedule in your practice. So can you walk us through what that looks like?
So I can't take credit for inventing this. I'm also on staff at the University of Illinois at Chicago. I teach endo residents there, and the university is actually the one that actually came up with it for their department. And we like that idea so much. My partner and I are we're both instructors there. We said, you know what? We've got to implement that at our clinic. It just makes logical sense to us. So we've got two specific teams that are actually in treatment or in actually seeing patients right now. It's myself and my partner. Each team has 2 chairside team members and 1 front office team member. And these teams are scheduled 5 days on, 5 days off. And the way we split it up is we don't do straight Monday through Friday, because I want to be available at least once or twice a week for my patients. And my partner also needs to be available once or twice a week for his specific patients. So our schedule starts on Thursday. It's a Thursday, Friday for one team. Then we have Saturday and Sunday off. So we kind of break up that day a little bit. Then it carries on into the next week with a Monday, Tuesday, Wednesday. And then at that Thursday, the second team takes over. So if we look at a Monday through Friday split, it's a 3-day, then the 5 days off, and then 2 days, then 2 days off, then 3 days, then 5 days off. So it works out really, really well. Granted, at some point in time, we're going to have to figure out how that's going to look when we are both here together. And I don't know when that's going to be and when we're all going to feel safe about having more people here together. But right now, that split has worked really well. Now, in the event that one of the team members does come down with symptoms and test positive for COVID-19, well, then we're going to quarantine that team, because we have to assume that if one team member has been exposed, then the entire team could have been exposed. So then that entire team will then be on quarantine for the allotted 2-week period of time or whatever is recommended. And that second team will then take over as long as they possibly can. In the event that both teams go down for whatever reason, we have a third clinician and additional team members that are ready to step in and fill that gap space, because it is so important to keep people out of the emergency rooms, which then begs the next question is, what do we consider to be an emergency? when we first started doing these sorts of things back in March, we'd have people with a little bit of a, well, it hurts a little bit here when I tap on it. I can manage with the ibuprofen, but it's not bad. And we start kicking that can down the road. But the
Yeah.
people that we were pushing down the road a month ago are now in emergency room pain now. So we are sitting there trying to figure out what our strategy is going to be for the end of April and through May. Because it's my feeling that at least here in Chicago and Illinois, that we're going to be extending this stay-at-home order at least through mid-May. It hasn't been announced officially yet, but it's coming down, I believe, to at least mid-May, maybe even beginning of June. So now we've got to try to figure out, do we qualify just mild pain now as an emergency, or do we wait till it becomes 10 out of 10 pain? Because
Right.
it's going to happen. So I'd rather see somebody with mild pain now as opposed to having to deal with somebody with emergency room pain a week from now, because it's more difficult for me to get them numb. It's more difficult for me to get them treatment. It's more dangerous if we have a large spreading infection, and there's only so much time that I can put somebody on antibiotics. So we're going to have to start maybe relaxing these strict emergency protocols. Like, consider saying, well, maybe a little mild pulpitis is now considered an emergency before it becomes a major pulpitis, and I'm getting that call at 1 a.m. So, I don't mind telephone calls after work, but if I can avoid treating a 10 out of 10 pain in exchange for a 3 out of 10 pain, it's going to make my treatment and the patient's experience a heck of a lot better.
Yeah, you're not kidding. I think it's important to just sit back, take a minute to connect with staff and try to figure out, how are we going to triage these patients when they come in? How are we going to figure out our strategies the first 3 months into 6 months, and then maybe take some of these protocols past that? How much do you think, honestly, from a military standpoint, did that help you and your staff figure out, like, kind of the layout for your own practice?
100%. My partner is ex-Navy. I'm ex-Air Force. I mean, we both are cut from the same cloth, and that's why we work so well together.
Yeah.
We are extremely regimented. We're extremely disciplined with everything we do, from the way we run our practice. And now it just kind of blended in to instituting these new protocols. And it's, so from my experience, having that training, having that what we call combat casualty care course, everything that we have to take before we go overseas, triaging things. Because in the military setting, when I was over in the Middle East for those first wave Enduring Freedom, dentists were actually trained as field triage people. So when people would come to the tent, we'd have to decide who gets in and who doesn't get in. Now, fortunately, I wasn't there long enough to see any major trauma from a battlefield or anything like that, but I did happen to have to see all the dental emergencies that came through. So you've got to learn on who needs to be patched up and can move forward, or who's in a serious enough condition that you got to pull you, and we've got to send you back to Ramstein, which is a German base which was close to the Middle East, or somewhere in Avion, Italy, or somewhere like that, where we have to say, well, you can't go forward to Afghanistan. You must go to a larger field hospital, or a larger, more comprehensive hospital in order to manage something like this. Because endodontics is a needs-based practice. People need that treatment. They don't plan for treatment, and rarely are people scheduling for these things. I mean, we can see consults, and again, we can kind of spoon feed people along and baby their mild pains, but when they're in pain, that decision is made for them. And either we're here to help them, or they go to the overcrowded emergency room. They run the risk of getting further health conditions. So all that training is probably culminated here in this event right now in 2020.
Yeah. I think that's what piqued my interest as well. As I wasn't in the military, but heavy military background in our family. And I remember stories that my dad would tell me about Vietnam, and, he was a corpsman in the Navy, and my mom was also a Navy nurse. And so, you're always thinking of, like, okay, risk benefit, and, like, how can we have the least collateral damage with what we're doing, and being able to spend our time effectively with the people that need it the most. So thank you for being on the front lines. I know that you've actually got to get back to work today. This is food for thought for our community. I know everybody's concerned about what this whole landscape is going to look like when we get back to work. So I think we just need to pause, take a minute to really strategically plan on how we're going to open those doors and be there as best we can for our patients. So I appreciate you, Dr. Nudera.
Hey, would you mind if I gave my YouTube channel a plug and all that?
Yeah, go ahead. Sure.
All right. So if you want to follow me, I've got a really wonderful educational channel on YouTube that just launched this year. It's Nudera Endodontics. You can also follow me on Facebook at Nudera Endodontics and Instagram at Nudera_endodontics. So I invite everybody to join me. I'm huge into education, and I'm happy to answer any questions that they should come up. So if anybody reaches out to you through your YouTube channel and you want to forward that question along to me, I'm always accessible. Please don't hesitate to reach out.
Yeah, that's what I was going to say. If you have any questions, if you want to continue this conversation, you can leave a comment below. If you want to nerd out on some endo procedures, this is the guy. I saw your channel. You've got a few videos going. They're very well done.
I appreciate this opportunity for me to speak to your audience, and hopefully we get to meet sometime soon.
Thank you so much.
All right,
Take
bye-bye.
care. Oh, okay. Well, that's news to me. Like, you need to update your bio.
Probably should.
On the new dent. Oh, you know what? National Endodontist Week is coming up pretty soon here.
Oh, maybe we should do another one of these.
It's in May. Yeah, let's do a little collaboration. I think that needs to happen.
I'm up for it. You keep me, just reach out to me and we'll figure it out.